Evening, everyone. I welcome everyone present here for this evening's webinar. Before we begin the proceedings, I would like to give a brief introduction to FACEMI and then a brief introduction to the topic before we proceed with the topic with the talk today. FACEMI, as most of us know, but this is just for a few of them who have joined for the first time, and also for us to reiterate as to what we really believe in as a group. FACEMI, Families Alliance on Mental Illness India, was founded by Dr. Nirmala Srinivasan. FACEMI operates at a pan-India level to ensure optimal scope for delivery of psychiatric services provided by the government, particularly in urban metros and cities. We operate as a community of family volunteers working for the wellness, security, and dignity of our loved ones under treatment for mental illness. We use the terms carer instead of caregiver and loved one instead of consumers or users. The responsibility of care and not burden of care. We use the word family in an inclusive sense of all the members in the family. We have FACEMI in 4 zones in India: Maitri in Bangalore, Shanti in Delhi, Shakti in Kolkata, and FAVMI in Mumbai. I would also like to take the opportunity to introduce the topic for today. You can see on the screen here that Saraswati has displayed. You can see the 4 zones and the phone numbers. If anybody doesn't have them, you can please note them down, or we'll also put it at the end of the meeting. We can also put it up in the chat box. As far as the meeting of today's webinar is concerned, mental health disorders have posed an immense challenge for early detection, diagnosis, and getting medication and sticking to it for many years. There is stigma around taking medicines as one is unsure as to how it will help and whether they cause sleepiness, the myth of addiction, and other medical problems. There has been a push in psychopharmacology even faster as mental health disorders have also increased. So research for chronic disorders and serious disorders like schizophrenia have been ongoing for a very long time. Development of new medication is changing mental health care, making it accessible, more targeted, and with lesser side effects, and helping people perform activities of daily living and helping in recovery also. Medicines personalized based on receptors and genetics are slowly bridging the gap between scientific knowledge and patient care. Can AI fasten the molecular research progress along with new psychosocial interventions? We welcome Dr. Krishna Prasad to provide a crystal ball on how new medicines, molecules, new technologies like digital technology can help in recovering and promote mental well-being and maybe obliterate the suffering caused to the person and families in the near future. Welcome, Dr. Krishna Prasad. I would like to say just a couple of lines about Dr. Krishna Prasad. He has done his MBBS from Bangalore Medical College and his MD in psychiatry from NIMHANS. He works as a psychiatrist at NIMHANS now. Welcome, Dr. Krishna Prasad. Over to you.
Thank you, ma'am. I'll share my slides. Are the slides visible?
Yes, doctor. Yeah.
Yeah, so I thought I'll restrict myself to new medicines for mental illness. Of course, questions that are related to technology, maybe to the extent that we can probably look at them, also is something that we could perhaps respond later towards the presentation. Now, for much of what we psychiatrists prescribe, we largely have a few categories, which are broad categories, which are currently used as medications for treatment of several of the psychiatric disorders. And many of these medications, though with specific labels such as antipsychotics, need not necessarily be restricted in terms of their use for psychosis or psychosis-like conditions, but also for several other disorders also they find their use. Similarly, though we have a broad label of antidepressants, meaning that these are perhaps used primarily in depression, but they also kind of serve as drugs that are used in the treatment of anxiety disorders also. So mood stabilizers, a large number of the mood stabilizers are also used in the treatment of other conditions like epilepsy. And sedatives and hypnotics are used for several other reasons besides their benefits with sedation also. Some of them serving as anti-epileptics. Also, some of them are used in alcohol withdrawal related issues as well. So then there is another category of drugs which is specifically used in the context of side effects which people with mental illness who are prescribed antipsychotics sometimes face. In this category of drugs is called the anticholinergic class of drugs, and many of these drugs belong to different chemical classes, and their chemical names and the chemical classes are different. But for the purposes of ease and also understanding, perhaps this classification in that sense is helpful. Whenever a new drug is brought into the market, I think as a first step, uh, there is some degree of research that begins in the laboratory. Uh, as a step two, perhaps after the laboratory testing, some degree of animal testing is done to answer the basic questions about safety of the drug. To an extent, its mechanism of action or how it kind of has effects on animal models is also perhaps looked at in step two. In step three, it is actually tested in usually first with healthy volunteers to see if there are any major tolerability issues that people have, and then subsequently on people with particular disorders to make sure that they are effective. Once that is done, usually approvals are sought, and the safety of the drug is also monitored in step four once the product is available for use by the public. This is basically to look at what are the different stages of drug development that happens. Though these are steps that one would think are uh, very logical steps for people to look at, particularly in the context of any of the disorders where pathophysiology is well understood. But in the context of psychiatry, I think many things have happened very serendipitously. When we say serendipitously, I think it must have been to an extent accidental discoveries. So whether it was with the discovery of lithium for its use in bipolar disorder, or whether it was with the context of chlorpromazine, which was the first antipsychotic which was discovered. Primarily, it was in the context of use by an anesthetist that its sedative and calming properties were recognized, or the accidental finding of uh, people who are treated for tuberculosis had become more active when they were given uh, drugs which are supposedly related to chemically to anti-tubercular drugs, and they found that they also improved people's energy levels, activity levels, and their mood to an extent, and that began investigation into the uh, to a class of drugs which were initially thought of as useful antidepressants. Similarly, with other antidepressants like imipramine, and also with the benzodiazepines, one of the early benzodiazepines, chlordiazepoxide, and similarly with other drugs also, which are somewhere parallelly or to an extent related to psychiatry, like sildenafil. So the uses for which they were initially thought of were different from what they finally ended up being useful for. So I think some time back we had looked at third generation antipsychotics, and in that context, maybe we had discussed how some of the antipsychotics which were initially discovered in the 1950s, like chlorpromazine or haloperidol. Some of you may still have people amongst your loved ones who for whom haloperidol or some of these drugs like trifluperazine may be continued to be prescribed, and but they are drugs that were
Okay.
initially discovered in the process of treating patients with psychosis or schizophrenia like disorders in the beginning of the journey of the use of antipsychotics. So many of these drugs are no longer in popular use. For example, drugs like
हम्म,
thioridazine,
ये सब एक साथ करते हैं क्यों?
pimozide, may not be in vogue or use now.
Hmm.
And somewhere in the 1980s and 90s, the second generation antipsychotics began to be available in the markets. But both with the first generation and with the second generation antipsychotics, there, while the second generation antipsychotics came about, the hope was that the movement disorders that people with the first generation antipsychotics, the people were facing, I think those were to come with, I mean, the second generation antipsychotics. It was expected that this would be less. So to an extent, the movement disorders and the other issues that were seen with the first generation antipsychotics were far fewer with the second generation antipsychotics, but they also brought with them unique challenges which are manifest in the form of metabolic side effects like weight gain, or over long periods when used, other symptoms, other syndromes such as metabolic syndrome, in which people experience conditions like diabetes mellitus, hypertension, and the consequences of these conditions. So, though they were expected to bring about improvement in um, both positive and negative symptoms, the expectations were not really met as far as the negative symptoms are concerned, and response rates were fairly similar to first generation antipsychotics. So then people fell back on the drug called clozapine whenever people were faced with resistance in terms of response to two or three antipsychotics, either of the first generation or second generation antipsychotic classes. Then with the third generation antipsychotics, the expectations were that the metabolic side effects were and the other hormonal side effects are far fewer. But again, the effectiveness and in terms of the practical use, it was seen that not much is different when you look at the three classes of or three generations of drugs. So while most of these drugs work through uh, chemicals called as dopamine or serotonin in the brain, uh, and they have specific receptors in the brain through which they work, and many of them are metabolized through the liver. So they are actually in a way worked upon by the body through the liver to break them down into products that are excreted. Many of these antipsychotics the levels can be, their blood levels can be affected because of use of tobacco or smoking in particular, and that can reduce uh, the the blood levels of these antipsychotics, and hence their effectiveness in individual persons who are prescribed these antipsychotics. And rarely some antipsychotics can cause fatal side effects, like for example with clozapine, and some of the other antipsychotics can also cause rare fatal side effects as well, though most of them are generally otherwise associated with problematic side effects, but not fatal side effects. One of the recent additions to the treatment armamentarium has been this uh, drug which has been marketed with this name, Cobin 5, and it has two ingredients in it, xanomeline and trospium chloride. And the the unique selling point perhaps of this drug is its different mechanism of action to whatever antipsychotics have been used until now, that it specifically targets a set of receptors called as the cholinergic receptors, and I think in that sense it is different in terms of its mechanism of action. And it has been at least advertised with better tolerability in terms of weight gain and movement disorders, and perhaps it is explained because of its the way it is acting on the various receptors in the brain and other body parts. Because xanomeline is the active ingredient and it can cause urinary retention, to mitigate that, the other agent, that is trospium, is added. But yet, people sometimes have reported urinary retention in whatever data is available from the United States. However, what is not known is what is its long-term effectiveness and what could be the long-term side effects with the use of this agent in a real world. Another drug which has been approved in the United States is lumateperone. And again, the mechanism of action is not very different from the other atypical antipsychotics. And it has been approved in the United States for use in schizophrenia and for bipolar depression. And the claims have been that it has lesser of the motor adverse effects or the movement disorders that people experience. And it doesn't perhaps have so much effect on uh, the endocrinological or the cardiometabolic issues that the other atypical antipsychotics or the second generation antipsychotics have. But there has been recently some concern whether it may have some degree of liver toxicity. So, but as of now, it has been approved in the United States at least for uh, treatment of schizophrenia and bipolar depression. One of the useful antipsychotics, which however
क्या खोला है
however
12 क्या खोला है 12 खोला है
has been associated with the uh,
कोई भी है
weight gain, which has
अच्छा
been a major issue,
ठीक है
and the consequent issues with weight gain and diabetes mellitus has been olanzapine. And olanzapine generally has lesser side effects as far as movement related issues are concerned, involuntary movements are concerned. So, but the weight gain and the metabolic side effects are enormous. So, a drug which is actually a synthetic opiate called samidorphan has been looked at if it can be added to olanzapine, and it has been found that when it is combined with olanzapine, the olanzapine related weight gain is kind of mitigated. So it has been used in the US for both bipolar disorder and schizophrenia. And the experience, as far as at least the metabolic side effects of olanzapine are concerned, have been positive. Now, one of the challenges that people face with the uh, treatment resistance and its associated other concerns are lack of insight, and the consequence that happens with that is usually there is poor adherence to treatment. So, in some countries, clozapine is also available as an intramuscular preparation. I think it is available in the United Kingdom and in Australia and in the Netherlands. And it has been used in those countries when people wish to treat persons with mental illness in the form of a supported admission. Uh, and it is probably a means of transitioning to oral clozapine in cases of treatment resistance. So in the United Kingdom, it is available as a Dutch product which is unlicensed, and it is available in the form of ampules, which is administered into uh, the gluteal muscles on the buttocks. And again, there are restrictions how it has to be used and for how many days it has to be used. And one of the major issues that people who have used intramuscular clozapine is that people complain of extreme pain, and some people experience local nodules with use of this intramuscular clozapine. Uh, People also have looked at hormonal treatment for several of the psychiatric conditions, and one of the uh, agents that has been recently marketed even in India is endoxifen in bipolar disorder, and particularly in the context of mania. So, besides being a hormone receptor modulator, it is also having a specific property which many of the other drugs which are used in uh, the treatment of bipolar disorder have action on an enzyme called as protein kinase. So it is closely related to a drug which is used in breast cancer, and it's a metabolite of that drug. It has been marketed in the United States as a with a decent scientific evidence, but the evidence is very limited as far as what we understand from people who have looked at it critically. And the long-term side effects with this drug are not known. Somewhere the original molecule of tamoxifen, which is used for treatment for other reasons in women, has been linked to depression. So whether this really endoxifen in the long term also has some psychiatric side effects is not clearly evident as of now. Uh, Again, another related hormonal treatment has been looked at in the context of postpartum depression. So, allopregnanolone, which is marketed as brexanolone, is used as intravenous infusions over 2 or 3 days in the treatment of postpartum depression. Again, it has been found to be effective in cases of specifically in the context of postpartum depression. So, an oral substitute for this hormonal agent is also something that has been looked at. These findings are very preliminary, though it has been published in the American Journal of Psychiatry, but I think these findings are very preliminary, and it is specific to the context of postpartum depression that these drugs have been found useful. Uh, some of you may have family members who have been prescribed with a drug which is used for anxiety called buspirone. A related drug called gepirone has been recently approved in the United States for depression. It has been approved mainly for unipolar depression, and it has not received approval for bipolar depression. However, since it is very similar to buspirone in its chemical structure, it is expected that it may have some effect in generalized anxiety disorder. And it also, to an extent, has some some positive effects in terms of the sexual side effects that people face with other antidepressants. So that may confer some advantage for this agent. Interestingly, its application for approval was rejected 3 times before for reasons of lack of effectiveness. But I think the fourth time, the company was able to convince that this is perhaps a useful treatment for depression. So it is available as an extended release, as an extended release single dose preparation also. Another agent which is now available in our context for treatment is ketamine, and ketamine is used generally in anesthesia, but it has been found that intravenous subanesthetic doses, that is, doses that are uh, not necessarily anesthetic doses, but far lesser than that, initially were found to be useful for suicidality and then subsequently for depression as well. There are challenges with the use of ketamine. No one really knows for how long one could prescribe uh, ketamine. And it also has some issues in terms of the problems with the recreational use because it is psychedelic in a sense and related to other psychedelic drugs. In the context of abuse of similar psychedelic drugs, there have been some neuropathological lesions which have been described with the chronic use. So one really doesn't know with the chronic use whether these are consequences because of what is called as excitotoxicity, damages that happen to the brain may happen. There are other issues with the use of ketamine, particularly because it can increase the blood pressure, and in some people they may have urinary bladder related issues. Because it is given intravenously and sometimes even intramuscularly, uh, alternatives like intranasal ketamine are also available. Uh, Increasingly, several countries outside India, there is a strong movement towards uh, seeking psychedelics as a treatment option. And I think initially itself, it was perhaps with that intent and with the benefits that came with the use of psychedelics that people were looking at psychedelics as an option, particularly in the context of disorders like post-traumatic stress disorder and sometimes in the context of substance use disorders, including smoking. Also, in the context of common mental disorders and like anxiety and depression. And in fact, in August 2024, MDMA, which is a drug of abuse in several countries, including ours, came close to approval in the US for treatment of post-traumatic stress disorder. But I think finally the approval authorities there took a call not to approve MDMA without safeguards in place. There are people who also look at psychotherapy being assisted with the use of psychedelics also. Uh, uh, Cannabis has been reported to have a lot of issues as far as mental health is concerned, and of course, it has effects on, I mean, in terms of anxiety, in terms of mood issues, in terms of psychosis, and several other mental health issues as well. However, I think with the synthetic cannabis-like products, there have been experiences of use in terms of specifically in the context of seizure disorder or specific types of epilepsy, where these drugs have been found to be useful. And another indication where approvals have been gained are in the form of uh, chemotherapy-induced nausea and vomiting. Also, there are reports of it being useful, particularly in the context of chronic pain and in multiple sclerosis also. So that they are useful for the treatment of psychiatric disorders. Uh, there is very little data as of now, though there are proponents for looking at cannabinoids as a potential option for particularly for mood and anxiety disorders. This drug tofisopam has been in the market for some time in our context also. It is very similar to many of the other sedative or sleep-inducing drugs like clonazepam and diazepam, as far as the chemical class is concerned. However, it is without the sedative, hypnotic, or muscle relaxant effects of these drugs, and it has been found to be useful in depression and anxiety disorder, and also it to an extent may act as a stimulant. Recently, other uses for this drug in terms of its use in gout and irritable bowel syndrome are also being looked at. Uh, One of the issues with the use of both, primarily with first generation antipsychotics and also with second generation antipsychotics, is the issue of movement disorders that develop slowly and over a period of time, which can in some people become very disabling. And the treatment options that are available for tardive dyskinesia or this movement disorder that develops are very limited. That people are limited to the extent that really very, very little can be done in terms of besides probably looking at alternative agents for treatment, vitamin E, and sometimes tetrabenazine, and for suppressing clozapine is sometimes also used. But each of these is also carrying its own set of issues and side effects. Valbenazine has been proposed as an alternative with fewer side effects, and unlike tetrabenazine, which has to be given 2 or 3 times in a day, valbenazine may require to be given only once daily. So these are some agents, at least, that have brought some hope, at least for tardive dyskinesia. Another uh, context where perhaps improvement or advancement is required is in the context of agitation. So in the United States, inhaled loxapine apparently is available. Loxapine is a first generation antipsychotic which for oral use was available earlier. But in the United States, it has been uh, looked at as an alternative approach to agitation. Uh, and it actually requires a single use handheld device, and the person has to actually actively exhale and then inhale and hold their breath for up to 10 seconds. So if this is the degree of cooperation that is required, one really wonders how agitated patients are likely to use uh, this agent, inhaled loxapine. Yet, I think this is available as an option there. Uh, Similarly, intranasal olanzapine is in the process of development, at least for uh, dealing with people who are agitated. Uh, I think when we look at the use of the existing drugs, we know that for many of the drugs, we look at like drug monitoring, and we do that very often for drugs like lithium. We also do that for drugs like valproate, carbamazepine, to an extent in some places lamotrigine, and also drugs like clozapine. The hope is that an adequate drug level in the blood would also mean an adequate drug level in the brain, and that perhaps would lead to good response in people. But
आप करो बेटा
but this is actually modulated by several factors because uh, age, gender, all of these will also determine as to what extent the drug is metabolized in the body. and also existing other medical conditions and treatments that are given for these medical conditions and the genetic makeup of the individual. All of this would influence the amount of drug that is made available both in the blood and the brain. So, to an extent, it may be useful to monitor the adherence to treatment and also the adequacy of the dose. So, to that extent, for some drugs, therapeutic drug monitoring is available, but not for all drugs. So, it also kind of helps us to look at uh, making judgments about the current doses and maybe also looking at adjusting the dose. Uh, so as I told, I think it's for a limited number of drugs that currently people uh, do the therapeutic drug monitoring, and uh, actually in practice, the use of even if you look at what happens even in tertiary care settings like NIMHANS, I think the level of monitoring that one would expect as per guidelines, perhaps either this because of systemic issues or because of issues related to accessibility, people are unable to actually follow those guidelines as far as say at least with exemplified with the use of lithium and clozapine and the blood levels that are done for them. So with other antipsychotics and with antidepressants, the availability of TDMs are limited, and it takes a long time even when it is done. So basically, utilization in practice is poor. Uh, Also, to an extent, I think there is an element of prescription laziness sometimes that happens. I have also personally seen underutilization of lithium, and when indicated, even when indicated, because of the several issues that people find with the use of lithium in terms of frequent monitoring that is required, and similarly also with clozapine. So sometimes people have used the word clozophobia. Even doctors are hesitant to prescribe clozapine because it involves more work, more explanation, and more issues to face with, besides the family's own apprehension sometimes. Also, the other agents which are less often used are the long-acting injectables, and very often it is underutilized. And there are several antidepressants which are there in the armamentarium, but besides the common three or four, many others actually don't find prescriptions nowadays. Finally, I think when we look at the choice of drugs, when you discuss with your doctor about your family member or for yourself, I think issues of concern are in terms of the safety of the medicine. For example, if it is an antipsychotic, it is with the safety of the antipsychotic. What kind of side effects do these medications cause? Uh, how effective is it in controlling the symptoms? And of course, price and cost of the medicine also, besides availability and access to the medicine, also become important. So usually it's a collaborative decision that one needs to take. So, and you need to jointly discuss with the doctor about what are the issues surrounding each of these points that I have put up here. So I think most of us, in the hope that many of us also uh, look for quick responses, and we all have a quest for cure. Obviously, it is expected that when we look at disorders, and sometimes these disorders are looked up as diseases, so then we look for cure, and there are chances of resistance to conventional treatment, even with though clozapine is regarded as the drug for use in treatment resistance. We do face people who have a large number of people, nearly two-thirds, who are on clozapine, who don't respond to clozapine or respond partially to clozapine. So there is a element of resistance that is available to conventional treatments. Then the options become very limited. In select cases, ECT can be effective, and one should not discount its effectiveness just because it involves exposure to anesthesia. So we have found that families are very apprehensive sometimes about the use of ECT. If done properly and with sufficient precautions and proper consent, it can be effective in select cases. So one should not, however, underestimate the use of psychosocial interventions even with the even with the use of the antipsychotics or with the use of mood stabilizers. And most important ingredient, perhaps, is the relationship and the trust that the person who has mental illness and also the family has with the prescriber. I think, yeah, this is the last slide. Thank you.
Thank you, Dr. Krishna Prasad. I request now Dr. Sachin to moderate the question answer session. There are a few questions in the chat box. I request the members to kindly post your questions in the chat box, and Dr. Sachin will now take it forward.
Uh, Hello, Sindhuja. Hi. Good evening. Thank you very much. Thank you, Dr. Krishna Prasad. Thank you for your wonderful lecture. I'll just quickly start with the first question, which I see in the chat box. Uh, I wanted to know any data available on replacing clozapine with new medicine.
No, in fact, we don't have a suitable alternative which is there for clozapine. Of course, doctors will look at adding an agent to clozapine and see if that is effective. But nobody really has studied um, what happens next with following clozapine resistance in terms of data that way.
Thank you, sir. My son Varun is taking lithium 800 and Olimel 5 milligrams since the last 3 years. He is gaining weight. He also has sedentary habits. He is under treatment for bipolar disorder. Can Cobenfy or lumateperone help him?
I don't think so. There is data to answer this specific question. What has been found is that Cobenfy and lumateperone are effective in schizophrenia for whatever period that they have been studied in those uh, trials that were done. Uh, they can be alternatives, but they are currently not available here. That is the first response. The second response is that you should perhaps look at other reasons for which he could be gaining weight. For example, if he's on lithium, whether the thyroid functions have been tested, whether his condition permits reduction in the dose of Olimelt. So all of these are conditions that can be discussed. If it is not possible to do anything with the dose, and if there is no thyroid related issues, whether he can be engaged in any form to improve his physical activity or examine his diet, I think those are things that can be done at this point of time. If replacing lithium or olanzapine with with another alternative is not likely to be helpful, as determined in a discussion that you have with the doctor.
Thank you, sir. Uh, One general question is, how do you manage the side effects of antipsychotics?
No, I think it depends on what side effects the person is experiencing. If it is typically what you see as the extrapyramidal or the movement disorder kind of side effects, as I mentioned, prescription of certain drugs like trihexyphenidyl or what is typically available as Parkin or Bexol or Pacitane is useful to mitigate some of those Parkinson's-like side effects that antipsychotics can have. With regards to weight gain, people have looked at adding drugs which can kind of reduce weight, reduce hunger. Uh, Facing, I think, less sedating alternatives can be looked at if reduction of the dose is something that can be examined. So these are some things that can be done. There are some side effects which might require monitoring. For example, with the use of lithium, you might want to look at the levels of the lithium. You might want to look at the kidney functions that the person is having. Also look at liver function sometimes. So it depends on the agent that has been prescribed, and the doctor. In discussion with the doctor, you may wish to understand as to uh, what tests need to be done at the baseline, what tests need to be repeated over a period of time. And I think that is dependent on both the agent that is prescribed and the physical health sometimes of your family member.
Thank you, sir. What about cariprazine? What are the side effects and how long term can it be used?
Its side effects are sometimes very similar to other antipsychotics, though it has, being a third generation antipsychotics, the expectation is that its side effects in terms of movement disorders and weight gain are far lesser, and sedation is also less. But I have had people who have complained of sedation with low doses as well. And also the other side effects some people have reported. Now, in the long term, one really doesn't know because the experience of use with cariprazine is very recent. So, but I don't think so it will be much different from the other antipsychotics that are in use.
Thank you, sir. What are the side effects of haloperidol 5 milligrams?
Haloperidol, I mean, specifically the dose of 5 milligram, one wouldn't be able to say, but at least haloperidol is known to cause motor side effects or Parkinson-like side effects. Uh, it can cause restlessness in some people. Uh, but I think if there are benefits with its use, I think they far outweigh any subjective experience of experiencing side effects. I think it should be continued. Otherwise, it's fairly safely used in most people, and it's also used often in the context of emergency when people require injectable antipsychotic.
Yeah, thank you. Are there suitable medications for treatment of managing EOPD personality disorders?
To an extent, medications may be useful, but I think to manage issues surrounding mood instability and also to an extent to manage impulsivity and self-harm, but they are not cures for personality disorders.
Thank you, sir. What side effects of weight gain and antipsychotic and how to reverse these?
I think weight gain is an issue with the use of some drugs like olanzapine, clozapine, risperidone, and quetiapine, and sometimes even with chlorpromazine. Uh, the issue is that there are, I mean, you should look at alternatives in discussion with the doctor if any of these drugs can be replaced with other drugs which have less weight gaining propensity. That is one way. But if this drug alone has been effective for your ward, then you might have to look at adding some agent which can, to an extent, reduce weight. But again, those really don't have too much evidence. Addition of drugs like metformin, which is used in the treatment of diabetes, or sometimes drugs like topiramate, which are used. And there are some other diabetes specific drugs which have been purported to have use in the context of weight gain. And as I mentioned, one of the combinations that comes with olanzapine, all of these are potential options. But I think pharmacological options alone should not be looked at, but other means uh, should be looked at in terms of reducing weight, both in terms of increasing the amount of physical activity or in terms of diet changes in diet. These are not easy to do, and particularly in the context of people who have a lot of negative symptoms and cognitive symptoms, it may be challenging. But I think as a part of the rehabilitation program, perhaps these are important issues also that need to be addressed.
Thank you, sir. Quick question. Is ariprazole at lower doses used as a dopamine agonist? My
Yeah,
doctor says so, and he's using this antipsychotic as a sort of
yeah,
antidepressant.
it
I'm
can.
taking 2 milligrams per day.
Yeah, it can serve as an antidepressant, and it can also, particularly in the context of women, it can also be used for changes that happen with the antipsychotics, particularly in the context of menses, what they call as either delayed or lesser flow of menses. So it can, to an extent, mitigate that side effect of other antipsychotics also at low doses.
Can a bipolar disorder person, since it's a genetic condition, manage his condition without using any antipsychotic drugs because of the fear of side effects?
I think this needs to be discussed with the doctor who is prescribing. It is to an extent possible that people may only limitedly require antipsychotics for phases of the illness, particularly mania, and in some situations, in the context of depression also. Uh, and there can be a possibility of using other agents like lithium or valproate or carbamazepine or oxcarbazepine as agents that are used for prophylaxis, that is for preventing the recurrence of the episodes. So it is possible that for short periods, antipsychotics may be required, but this has to be discussed with the doctor
Awesome.
concerned.
Awesome. Uh,
about long term.
I take Vapis DXT25 and Corate Chrono 200, Zapis 0.5 milligrams. I also have autoimmune issues. Please help me with the side effects. Vapis, Corate
Well,
Chrono
well,
200,
well.
and
Okay.
Zapis 0.5
Okay.
milligrams.
Yeah. So is it Zappis or
Now that's what I could read here.
okay.
Zapis.
Okay. Zappis. Okay. I have issues with autoimmune
Yeah,
issues. What specific
yeah, it's
autoimmune issues?
Zapis.
Yeah. What autoimmune issue?
Autoimmune, yeah, hypothyroid, osteoporosis, and vitiligo,
Uh,
and IBS.
okay. What kind of side effects are you experiencing?
Well, side effects. I mean, this Ventep DXT. I'm taking 1.5. My psychiatrist has increased the dose at night due to my depression. Okay. And side effects meaning like my father has Alzheimer at this age, you know. So sometimes I get absent-minded and forget things and all that. So is it connected? Like, and I'm underweight also, and I have a weak muscle.
Okay, I think since there are many issues involved, I don't want to provide any simplistic solution to your problems. It is quite possible that sometimes with the use of drugs like Zapis, you can experience some problems with absent-mindedness or some degree of difficulty with memory. But I don't want to jump the gun. Perhaps I
Okay.
think a discussion with your doctor, considering that there are many issues that are uh, there with both the physical health issues and mental health issues that you are experiencing. I think it should be carefully discussed and not maybe not look at quick fixes in the form of a consultation on this webinar.
Okay. Thank you.
Cariprazine and amisulpride are described. Anxiety are also increased. What is the solution?
Prescribed anxiety. I did not follow the question.
Yeah, cariprazine and amisulpride are prescribed. Anxiety has also increased. What is the solution? I think
Many of these drugs which are used as antipsychotics to an extent can also bring down anxiety. But I think whether there is an independent anxiety disorder that is there, again, that has to be discussed with the concerned doctor who is seeing the person with mental illness. And I think, and if that anxiety is actually something that requires treatment, is also something that one might need to discuss.
thank you. Thank you, sir. Can bipolar disorder convert into schizophrenia if the person is taking valproate 500 milligrams per day and taking alcohol and cigarettes without fail? Though doctor from IBHAS Government Hospital Delhi advised him 500 milligrams twice a day. He is having a SLD dyscalculia. I think this is thank you. So I think the question is, can bipolar disorder convert into schizophrenia if person is taking valproate and with cigarettes and alcohol?
We do see that sometimes. I think I saw Dr. Aris Murthy sir also um, on the call. So, but we do see people with mental illness sometimes change diagnosis because of several reasons. One is the natural course of the illness. We also see that sometimes because of iatrogenic reasons or reasons of treatment, the nature of the illness sometimes changes. So it is possible sometimes to see some degree of fluidity and instability in diagnosis uh, that you may receive. So I think again it depends on what kind of history the and symptoms the person has experienced. So, uh, but what I'm saying is that fluidity in terms of diagnosis is known, and stability of diagnosis also can sometimes be an issue in certain situations.
Thank you, sir. Is olanzapine 405 milligrams monthly injectable for schizophrenia have metabolic side effects?
Yeah, I think olanzapine, both injectable and oral forms, when prescribed alone, will have metabolic side effects.
Samidorphan, is it available in India? What is the cost?
No, to my knowledge, it is not available. This combination is not available in India.
No, thank you. Can Ozempic be used to reduce weight? I think you answered the question, but I'm still, because weight gain is a concern, as huge weight gain has occurred with clozapine and paliperidone. Clozapine resistance is there and higher doses cause side effects. Physical activity is not there, due to which symptoms are continuing. Metformin is also being given. So I think it's a repetition of the earlier questions, but I think weight gain is one, and metabolic issues are common questions over here.
Yeah, yeah. And then there are no easy solutions to many of these, I think, but looking at non-pharmacological approaches and working closely with a doctor to address physical health issues is an important aspect of well-being. I think it has to be discussed, not limiting the discussion to only mental health alone. I think when you have a collaborative discussion with the doctor, goals of treatment should also include weight reduction, perhaps, and maybe not looking simply at pharmacological means of reducing weight. Other alternatives to clozapine and paliperidone can also be discussed if that is possible.
Thank you, sir. I want to know about the effectiveness of TDCS therapy for depression and schizophrenia. So I don't understand what is TDCS. I think
Yeah, I think it's
TDC,
transcranial,
yeah.
yeah, direct current stimulation.
Mm.
Um, Personally, I have not had positive experiences with the use, but in certain situations, I think it can be useful, but not as a first line treatment, perhaps.
Okay, sir. Does ARIP cause high BP?
To my knowledge, no, but I mean, you will find if you look up the side effects of drugs, you will find that in certain instances, people may be prone to developing rarely some of these side effects, but it's not a commonly known side effect. Aripiprazole causing high blood pressure. In certain situations, say for example, if somebody develops something called as an neuroleptic malignant syndrome, then it is known to happen. Aripiprazole has lesser propensity to cause such a kind of a side effect. Yeah, but one really doesn't know in an individual case. It may sometimes happen, but it's not a commonly known side effect.
No, thank you, sir. Can clonazepam be given on a regular basis?
No, generally we don't recommend the use of uh, drugs like clonazepam for longer periods because obviously because of the issues surrounding uh, the addiction potential that some of these drugs can have. Also because of the fact that they can have other side effects in terms of falls sometimes, also with the issues surrounding ability to remember things and process information fast.
Yeah. Can bipolar disorder, borderline personality disorder, is there any treatment available? Oh,
There is, to an extent, I think I answered this question
yes.
earlier.
Which of the two increases weight as a side effect between valproate and fluoxetine?
I think valproate certainly would increase the weight more than fluoxetine.
What can be the side effects of taking Zappis 0.2 milligrams for a long term besides losing effectiveness?
Yeah, I think I mentioned already that it can cause, in some people, memory-related issues. It can cause, it can predispose people to falls sometimes.
Yeah,
It's also a
I
muscle
think,
relaxant and yeah, sedative.
yeah. And so one question, I think which you mentioned, but I'll still repeat it. Where can one try psychedelic medication therapy under supervision for treatment of chronic mental illness? I think you mentioned it, but still, I think to clarify
I
for
don't
people.
think so. It's available in our country. It is done in several settings in the United States, but not in our country.
Right, sir. I think this covers most of the questions. And maybe this one question which is there. Uh, are there Ayurvedic medicines which help as a supplement, and what are the side effects of risperidone 1 milligram long term?
Ayurvedic medicines, I'm perhaps not the right person to respond to this question, but I think there is some research on the use of uh, uh, certain category of Ayurvedic drugs for particularly the cognitive symptoms that people with chronic mental illness sometimes face. Uh, Other forms of treatment like yoga perhaps are more likely to be useful. Of course, you should consult a specialist in Ayurveda to respond to this question. And when somebody prescribes Ayurveda related medications, I think it becomes important to look at interactions that happen between the Ayurvedic medications and the medicines that are prescribed for mental illness. Some of the Ayurvedic medications sometimes can have psychiatric side effects. I think those are things that you might need to closely liaise with the Ayurvedic doctor who is prescribing your medicines, and also the allopathic doctor who is prescribing the psychotropic. And I think this discussion has to happen. At least in NIMHANS, there is a integrative medicine department where this discussion can happen in a single consultation. So that possibility is there in NIMHANS. But in other places, you might need to shuttle between the two doctors to know what kind of interactions they have or what kind of side effects each of them have.
Thank you, sir. Can Sizodon 2 milligrams, Miritas 7.5, Panazep 25, and Encorate Chrono cause IBS? I think this has come directly to me, but I'll just can Sizodon 2 milligrams, Miritas 7.5, Panazep 25, and Encorate Chrono cause IBS?
No, I don't think so. It can cause irritable bowel syndrome, but of course, some of these agents can cause constipation, so which can be a problem sometimes.
I think there are some diagnosis questions which maybe I'll ask in the last, but just quickly, do bipolar and anti-anxiety medicines cause hypothyroidism?
Medicines
Like
that are used for treatment of
anxiety and bipolar disorders
bipolar
cause
disorder, like lithium, at least has been associated with hypothyroidism. To an extent, drugs like quetiapine also have been linked to hypothyroidism, but not as much as lithium. With lithium, we regularly ask people to undergo thyroid hormone checks. With regards to anti-anxiety medicines, I don't think so. They've been directly linked to hypothyroidism.
okay. And, risperidone 1 milligram side effects longer. I think there's one question which come.
I think risperidone 1 milligram in the long run would require monitoring for sugars, would require monitoring for lipids, and also in some people, the distinct possibility of experiencing movement disorders. I think these are some things that periodic monitoring would be required for.
One common question: does changing antipsychotics mitigate its side effects? If you change your antipsychotics, does it reduce the side effects?
It is hard to answer, but one might need to take the risk if the side effects are too disabling.
Right, sir. Thank you. I think thank you for your patience and a quick fire question. There's one question which is more a diagnosis thing, so I'll just quickly ask. A patient who's prescribed more medicines with valproate, but he's only taking valproate once a day. I took the patient to PGI Chandigarh, AIMS, IBHAS, but doctors rarely speak about the symptoms, about his bipolar correctly, and never suggest to go to a psychologist. Uh, so I think this is more a general question, but it's difficult for the family members to make the patient understand. Please share my situation with the policymakers. I think this is just more a general question. There's one question: is lurasidone 40 milligrams for schizophrenia popular for constipation? I didn't understand this.
So I mean, many of these, at least lurasidone is not directly linked to constipation, but when you look at, if you look at the list of side effects that many of these uh, drugs have, uh, somewhere or the other you will find lurasidone being linked to constipation, but not popular or not commonly known, at least.
Yeah, yeah. Thank you, sir. Thank you for your patience and time. I think we're
Doctor,
running out
I
of
have
time.
one
Yeah,
question.
please go ahead. Please go ahead. Sir.
Yeah, so this is something which Nirmala ma'am has asked me to ask you. Okay, since she couldn't be part of this webinar today, families face this biggest challenge of, patients are not ready to take medicines. So, there's a lot of resistance. And is there any action plan among psychiatrists as how we can actually, take this resistance story, and have actually the patient taking the medicines?
The resistance sometimes can stem from the side effects that they have experienced with the use of the agents. So if such is the case, then I think detailed discussion with the person concerned about what kind of side effects. Very often it is side effects related to, say slowing of thinking, or very often it is the inability to experience pleasure, which they don't easily voice. Sometimes it is related to sexual side effects. Sometimes it's related to very obvious side effects like for example, weight gain, or for example, movement disorders, that they feel that they should not continue the medications. Sometimes it is also simply the fact that I'm taking these medicines for too long, and there is some degree of institutional control over me. So, or parental control. So, and I don't require the medicine since now symptoms are not there. So the reasons could be many. So similarly, I think adverse experiences in terms of the way the treatment was administered or the way the person was taken for treatment could also sometimes be a reason. Sometimes it could be plainly lack of insight into the illness. So it could be many factors, or the dosing of medications, or the obviousness of the side effects to uh, maybe colleagues at workplace. So there could be several reasons for which the person may not wish to take antipsychotics. So it can be dependent on a very one case by case basis. But yes, I think there is a proportion of people who don't have insight. And I think in that context, there are no direct or very, what to say, answers that will probably provide a fix for that question. I think periodically negotiating, ensuring that the person is not kind of forcibly taken unless there is a risk of harm to self or others, or there is significant caregiver issues that are faced. I think that has to be done in discussion with the concerned doctor. There may be certain situations where you might need to take the person for supported admission and treatment against their will, particularly in the context of, say, harm to oneself or harm to others. Other contexts, I think it is always a good idea to help establish a therapeutic relationship so that the person feels involved in the treatment. But it is sometimes challenging, and it can be a difficult question to answer.
Thank you, doctor. Yeah.
Yeah, thank you. Thank you, Dr. Vishnu. Thank you for your patience for quickly answering the questions. I just wanted to add, do you see any more receptors like glutamate, etc., which are being discovered for disorders? Any few new receptors except serotonin, dopamine, or glutamate, or anything which might get targeted? Would there be any biomarkers where people can predict psychosis and intervene early?
I think there are quests to look at each of these that you asked, both in terms of glutamate receptors. If you look at the psychedelics and the action of ketamine, it is primarily through the receptors that are related to glutamate. Similarly, an exactly opposite agent called GABA, which is where gepirone kind of drugs act. So there is this quest to look at different receptors, but we really don't know when we will find answers in terms of, and if at all, we will find answers in terms of pathophysiology of mental illness, because many of these are also contextually and socially uh, determined. So and psychologically determined. So it's not so simplistic to look at everything in terms of receptors.
तूने मेरा ही वाला दोबारा ऑन कर दिया है
We may, it's possible either ways that we may or may not find answers to these questions in terms of only medications. But I think it's not alone medications. In many cases, we do require other forms of support and engagement that people with mental illness require.
Thank you, sir. Thank you. I hand it over to Sindhuja. Thank you, sir,
Thank
for
you,
your
Dr.
time and
Sachin.
patience.
I think a lot of the questions were pertaining to the side effects of the medicines that their loved ones are already taking. So thank you very much, Dr. Krishna Prasad, for being so patient and answering all the questions so beautifully. And thank you very much for being with us here today. I would also like to take the opportunity to thank Dr. Sachin for moderating the question and answer session so well, and Saraswati and Ekta for providing the tech support and carrying this webinar through. And I also thank all the people who joined the meeting today. And I hope everybody found it very useful, as did we. So thank you, everyone. We would like to conclude the meeting with the FACEMI pledge. I request Saraswati to kindly share it on the screen. I request people to, all the members present, to kindly stay muted. I will read out the FACEMI pledge. You can read it along with me. The FACEMI pledge. We, the members of FACEMI's Families Alliance on Mental Illness, FACEMI, pledge to support one another and other families in similar situations, and use language which conveys love and respect towards each other and especially towards the PMI. We shall strive to protect and promote the rights of PMI as enshrined in the laws of the land. On this day, we take this pledge to work towards the vision and mission of FACEMI. Thank you, everyone. It was wonderful to have you all here today. Thank you, Dr. Krishna Prasad.
Thank you.
Thank you, doctor.
Thank you.
Thank you,
Thank you,
everybody.
sir. Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you. Thank you, doctor. Thank you, everyone.